Thank you. Now we're going to move to our first panel, Systems Change, Adapting to a New Reality. So I'll ask the panelists to take their seats on the stage. I would like to introduce our moderator for the first panel, Dr. Monique Parrish. The Director of Life Course Strategies. I've had the pleasure of working with Monique on multiple projects in this county, but she's really lent her expertise to initiatives throughout the Bay Area and beyond. Check out her bio for more information, and with that, Monique, take it away.
Thank you so much, and thank you, Mara. That was fantastic. And I was going to lead with some sort of a climate change metaphor, but immediately was dissuaded by that, so thank you for correcting me, right? That'd be awesome. Okay, what I took away from that, and I think it's a really lovely springboard for this panel, is about internal and external change, that dialogue, the cognition, how we think about things, and how our thoughts really play into how we perceive things, conceptualize them, and act. And it's a wonderful framing, I think, about how we think about that as individuals as well as systems, those larger communities that are really about promoting change and opportunity. So again, my hat goes off to you. I think it's a lovely springboard. So our Systems Change panel, this new reality, is the intersection of our systems as we conceive them and produce them, but also as they connect with people. All of us. It's our story together. So we are going to hear from some terrific leaders of systems here in Alameda County, and they're going to provide sort of the big picture overview of what they're doing and their charges and their commitments and their passion, and how that actually sort of plays out on that individual community level of programs and services, and sort of ending with what's the vision? Where do we go from here? So I'd like to introduce this terrific panel. You also have their bios, but well, I'm a little bit out of order here. So Marty Lynch is CEO of Lifelong Medical Care, and I had to do the math. If you look at his, he started in 1982, and this morning while I was getting prepared, I was like, all right, quickly. 35 years as the CEO of Lifelong Medical, 16 sites for that. Aside, I worked at one of his clinics for 10 years in East Oakland, so
we let her escape.
That's a lot of affection. We are also thrilled to have Rebecca Gebhardt, and she's the interim director of the Alameda County Healthcare Services Agency. I've also had the pleasure of working with Rebecca, and she's reporting to the County Board of Supervisors and oversees public health, environmental health, behavioral health, administration, indigent health care, and she is able to sleep at night. There we go. It's a huge, huge job. Randy Morris. So Richard, you're next. 20 years of experience as a healthcare administrator. He's the Chief Administrative Officer for Post-Acute Care for Alameda Health System. And that, too, carries with it a huge number of responsibilities, including oversight at Fairmount Hospital, acute rehabilitation, subacute services, skilled nursing, and outpatient rehabilitation system-wide. And finally, we have Randy Morris, the Assistant Director for Alameda County Social Services Agency and Adult and Aging Services Department. I actually work part-time with homeless women, and I actually had called his former agency, was doing some inquiry about Child Protective Services this week, and had an opportunity to speak with one of his former colleagues who told me to please say hello to him today. So he was formerly with the Children's Services Department. So we have a really terrific panel. And our challenge is to keep everybody to about 8 minutes. So with that, we're going to lead off with Rebecca for her presentation.
Today I'm going to do a quick walkthrough of the data and what it tells us about our county. I'm going to talk about the power, opportunity, and challenges in cross-systems work to improve services and life for older adults, me included, and caregivers, and talk about multiple initiatives that we're working on together. But first I want to say I thought that Moira's presentation was amazing, but it's made me totally self-conscious about my vocabulary. I have used the silver gray natural disaster term numerous times, so I am not going to be using that term, and it reminds me how language is really an incredibly powerful tool for change, and I'm signed up for the thing that's happening in the first quarter. I want to start also by saying that the Healthcare Services Agency is a massive agency. It's 1/4 of county government. And in the last 2 years that I have been privileged to serve as interim director, when the board asked me to do this, I immediately, jumped in and saw that the Healthcare Services Agency really accomplishes our goals 3 ways. As a regulator, to keep food, water, and air safe for our residents. As a safety net, we are a huge safety net provider of medical, dental, primary care services, behavioral health services, and we are a change agent. And today's conference is about making change. The Healthcare Services Agency was right at the forefront of the implementation of the Affordable Care Act, and based on our work, we had a really high penetration of the Medi-Cal expansion in our county. We work with government institutions to make change. We implement new policies. We are not like the stereotypic government. I like to think of the Healthcare Services Agency as activist government. And today's conference is focused on the change agent part and how government can be a powerful force for change when we partner with all of our public and CBO and private agencies across the county. So I'm going to do a fast walkthrough of the data. Okay, I can see it down there. And this is just evidence of our population growth. As Moira says, we need to state the facts about what is happening and not refer to it as a natural disaster. The number of older adults in Alameda County is projected to more than triple in size from 2010 to nearly over 500,000 in 2060. While the older adult population continues to grow, support services infrastructure has remained flat or has been cut. In terms of older adult socioeconomic status, 11% of older adults currently live in poverty, and 1 in 4 are making less than 200% of the federal poverty line, which means that in the Bay Area, they're struggling to make ends meet. This data shows the leading causes of hospitalization among older adults, which are heart disease, infectious parasitic disease, respiratory disorders, digestive system disorders, and injuries. And together, these account for about 60% of all hospitalizations among older adults. I'll also say that older adults represent a large and disproportionate share of hospitalizations, while older adults right now comprise 13% of the population in Alameda County. They consist of over 30% of hospitalizations. Older adult unintentional injury, ED visits by mechanism of injury, 50% falls. How many of you are involved in falls prevention work? We have a pretty robust system in Alameda County of falls prevention work, and that is going to be more and more important. This data shows preventable hospitalizations by age. So you can see preventable hospitalizations are inpatient hospital stays that could have been avoided with improved access to and quality of outpatient care and disease management. So this gives us a roadmap for where we could be investing. In Alameda County, most preventable hospitalizations are related to chronic disease as opposed to acute disease. And more than half of all preventable hospitalizations due to chronic disease are older adults 65 and over. This data suggests older adults have especially poor access to and or quality of outpatient care and disease management. So again, gives us a roadmap. And my final data slide is Alzheimer's. And we've been doing a lot of work with a work group on Alzheimer's, which I'll talk a little bit more about. But the projected number of people living with Alzheimer's/dementia, because they are not the same, will dramatically increase over the next few decades. The increase is driven by the increase in 85-plus-year-olds who have an over 30% prevalence rate, and those numbers are projected to increase 7-fold by 2060. This is just some more data on the cost of hospitalization related to Alzheimer's and dementia, and so you see as the population increase, the cost is going to increase. So these data were prepared by the Community Assessment, Planning, and Evaluation Unit of the Public Health Department, led by Jane Martin and her staff. She's also provided to us the first ever slide deck on Alzheimer's data that is specific to Alameda County. And these data give us really important information to help us figure out where we want to go, how we want to identify resources, and where we want to invest. So some of the implications of the data are here. As the cost and social burden of preventable hospitals is rising, the support services for older people has remained flat or reduced. And I think the most important point is obviously there's a need for increased funding, and that's what our cross-agency table is working on. There is a need for more comprehensive services, but I think for me, the most important phrase here is new solutions. New solutions for older adults in Alameda County, and I think this speaks to what Moira said, where we have an opportunity for ingenuity and to do things differently. So today's conference is about rethinking the status quo and how we work. Our work's been driven by our funding sources and our silos more and more, and I can say this, it's not just in the world of older adult services, this is in the world of criminal justice, mental health, this is in the world of school-based health services. Systems are learning that we cannot do it alone. That all of us, in my experience, and I just turned 59, in my experience, there's never been a higher appetite for cross-system collaboration and work. And no single agency can do their work alone, and systems leadership is critical to success. Partnerships across multiple systems allow for sharing of resources and ideas to identify gaps and possible solutions. And it's really important, I think, to be intentional about cross-systems leadership. If it was easy, we would have already done it. And to the extent that you can invest in your own leadership development around cross-systems leadership, I think it's a good idea. The Healthcare Services Agency has sponsored a program called Organizational Relationship Systems Coaching, or ORSC training. Do we have any ORSC trained people in the room? Cool. And it focuses on working across systems. So it's an important thing to look into. If you're interested, you can reach out to me and I can give you more information about the curriculum and the trainers. So I'm not going to stay too long in here because some of these cross-system collaborations you saw or heard about in the video, but we are doing a lot over the last 3 years. We have developed a table to identify projects and to move the work forward. That's the Council for Age-Friendly Communities, which I think Randy's going to talk a little bit more about. We have a whole person care pilot and expanded funding, $140 million of expanded funding, and that is an ambitious and innovative program that aims to improve health outcomes for homeless and other high utilizers of care while reducing cost, and many of these folks are older adults. We expect, and we are informing, that the program is called Alameda County Care Connect, and Dr. Clannon is the head of it. But we have the Senior Services Coalition. We have both plans, our public plan and our private plan. We have the Social Services Agency. We have all of our cross-system partners at the table as we've developed that program. So it's a really exciting opportunity. In addition, we have identified new funding to invest in older adults. We are investing more in injury prevention and nutrition and meals. We have invested more in home visiting, the nurse case management services, led by Angela Ball and Michelle Burke. We are investing more in hospice and palliative care, specifically in the Getting the Most Out of Life program, led by Marilyn Abavio. So There is a lot going on with respect to cross-system collaboration. We have a community paramedicine pilot that's a partnership between EMS, Alameda Hospital, and Alameda Health System, which connects clients who've been discharged to from the hospital with appropriate services so they won't be readmitted so quickly or at all. And we have our Alzheimer's and Dementia Working Group, which is bringing together a group of people, including community experts, to look at the data that was produced by our CAPE unit about Alzheimer's and dementia in Alameda County. And we're looking at the data, and we're looking at what the data tells us and what the data doesn't tell us. And our plan is to convene all of us together to figure out what we do next, how we invest, and how we prepare ourselves for a greater population and more resources and services to meet the needs of that population. We have behavioral health care, and I think a lot of you know our behavioral health care older adult system of care, led by Lillian Schechner, has amazing mobile services, early intervention, and evidence-based treatment models. I could go on and on about that program, but in particular, they have a geriatric assessment response team providing community and mobile outreach assessment, short-term counseling, referral, and other services. And this is a collaboration with social services, particularly Adult Protective Services and IHSS. And one other aspect of this program, which I want to mention, because across all areas, we're trying to focus more on culturally competent services. We're doing this a lot in hospice and palliative care. But in behavioral health, the IMPACT program, which is a culturally competent focused program focused on depression in older adults, it's being implemented in 2 community-based, culturally specific programs to address the needs of limited or non-English speaking older adults. These are being implemented at Asian Health Services and Tiburcio Vasquez. So just a minute on challenges, and then I'm going to wrap up. Working across silos is hard. If it was easy, it would be done. We all have different approaches. Our systems are different. We come from different lands. And so conflict and getting to know one another is an important part of the process. And developing those cross-system leadership skills and developing the ability to work with other systems and understand how they work and figure out how to solve problems together is really critical. Growing the capacity of new providers is also critical. Small, emerging, community-based providers, the faith community, people who have connection to community and ability to serve, we as government need to help them become able, basically, to work with government. Working with government is not easy. Getting government funding, being accountable in a government context is not easy. So we are working hard to provide additional technical assistance to bring small, emerging, and other organizations close to us so that we can work together to solve problems. What's on the horizon? We are doing a lot. All of these programs are going to continue. All of this cross-system leadership is going to continue. In particular, I wanted to mention that we are working with Nancy Frank, who also works with Marty and Steve Lustig in the city of Berkeley, on a health needs assessment across the county. And this, I think, is going to help guide fundraising and provide us with important data that we can use to raise money from philanthropy and from the federal government and the state government to expand our services. That work is being led by Nancy Frank, Andrea Dodge, and Eileen Yang. I want to say in closing that I just want to thank Wendy Peterson for her partnership and in planning this conference. Systems change is challenging, but the power of us all working together just can't be underestimated. And I'm a champion for the older adult work, and I look forward to continuing working with you all.
All right, we're going to turn to Marty Lynch, and I'm going to pass it over. Okay.
Thanks, Monique. Pleasure to be here with so many of my colleagues. I see lots of familiar faces. Also, I want to give a quick shout out to one of my bosses who's here, Edgar Quiros, who's on Lifelong's board, and a couple of my key staff people in the aging world, Catherine Stambaugh and Deborah Workman back at the back there. So, appreciate you guys. Couple of things. Let's just do the necessary back. Oh, I got to say, by the way, I don't get confused about pronouns these days. It's definitely we, or maybe it's I, when it comes to Asian, I'm afraid. And there's opportunities and there's hard parts. So Lifelong, just to give you an idea, is part of a community health center movement across the country. And I always like to update people on that movement. 26 million patients now across the country served by health centers. Here in we're often seen as moms and kids services, except for Lifelong, but really 2 million older people are served by community health centers. Lifelong itself is now serving 60,000 people up and down the East Bay, and you see where 6,000 of those are elders. So part of my job today is to think about where we're going as community-based providers. As an elder provider, we're much smaller. As a medical provider, we have a lot of patients, and we do a lot of work in that area. And of course, Lifelong comes out of the background of being founded by the Great Panthers as the over 60 health center. So that's in our heart. I always tell our new employees that I was lucky enough to get to train at the knee of these fantastic little old lady organizers who are the Great Panthers, were the Great Panthers in my starting days. So a couple of background pieces. I get to do some of the comment on what's going on in the bigger world. So let's not forget that Medicare and Medicaid, or Medi-Cal in California, are both under severe threat. You probably watched the House budget discussion recently. Both those programs are looking at cuts in that budget, and we just came off of fighting about the ACA, which was mostly about destroying Medicaid, which has provided most of the increasing coverage in this country under the ACA or Obamacare. But don't be fooled. Programs that serve aging from a social services point of view also will be under attack. You cannot get the dollar savings in government to give the tax cuts to the wealthy in this country that Trump wants to give without taking dollars out of many, many, many different programs. So I know we're all advocating around those issues. Also, background, remember, the only long-term services and supports system we have in this country right now is Medicaid for folks who spend down or are poor enough to use those. Another theme behind the healthcare world, which is going to relate to aging in a minute, is the volume to value movement. So we know that we've had programs that paid us to produce a lot of widgets, whether they be visits or procedures. We've gotten a little smarter and started to say we have to find the value in all this work we do. Again, I think that crosses over between aging and healthcare as well. And then finally, both Medi-Cal and Medicare, especially in this geographic area, will continue to be funneled through managed care health plans. So yes, I mean, it's clear on the Medi-Cal side. I know Michelle from the Alameda Alliance was here earlier. That's the Medicaid plan. Anthem is a smaller Medicaid plan for those folks. But on the Medicare side, don't forget that Kaiser has huge market penetration in the Medicare arena through its Medicare Advantage plans. So it's just important to know that as service providers, if we're going to get into that, we have to have some way to work with these entities. Okay, other factors that I see quickly. Obviously, we have the demographics growing as the money goes down. And we still have the silos that everybody's referred to so far. I think there's oh, hey, thanks, Monique. I should give this to you. Can I chew gum? I need all the help I can get, believe me. That's been true for a while, not just aging. I want a couple things, which is there's been some progress in integration. Let's just acknowledge them. Rebecca mentioned the Connect program or whole person care. We have the duals demos going on in other counties. In Alameda County, remember, we said no. We were supposed to go up, but because the Alliance was in difficult straits at the time, we said no, we're not going to go up with the duals demo in Alameda County. But those are efforts to make improvements in the silos and give some opportunities for us. I think, so how do I think about it as a community-based provider? First of all, we all know the dollars are not in the aging side, even though we wish they were. The dollars are in Medicare and Medi-Cal, Medicaid, in the healthcare side, but many of us don't have access to those. Lifelong itself is lucky because we're a primary care provider, so we have an in with the health plans and the hospitals and such. But we know we have to do more than that and think about this in a different way. And we think aging programs in this day and age have to think a little bit differently. So for us, and let's switch. Yeah. I think a couple of things. Number one, it's how do we think of ourselves not as controlled by our funders and what we've traditionally done, because we know how to do a set of services that are very important. Will we typically do them in a way that speaks to the folks that have funded us? And I think we're getting pushed to think more in terms of our potential customers, whether those customers be individual older people, whether they be the health plan, whether they be the hospital, whether they be some other entity. And it's not the way that I came up thinking. So when I think about that, where do I go? I go to people who, Rebecca had a slide that talks about preventable hospitalizations amongst the elderly. Well, that may not be what we do now, other than indirectly, but we're going to be doing that. We're all going to be doing that if we're going to tie into where the resources are. I think we're going to be in a world where data is shared, services are integrated, and we have to look at partners to do that integration. So it's very hard for me to see how all of our small social service and aging services entities will survive in times of tougher dollars unless they form partnerships. Now, one form of partnership Wendy was talking about the other day is, can you create a contracting entity, right? Not so easy, but maybe that group of aging providers can start thinking about what is our product. I'm an old community organizer, so I hate to think that way, but that is the way I think we have to think. What is it that our customers want from us, and how can we change our way of thinking and our way of being to provide that? And think, I mentioned hospitalizations for the health plans, but think for the hospital world, that's probably things like readmissions and such that they're getting penalized for. Now, and it doesn't mean that tomorrow any health plan is going to be willing to contract with an aging service provider who's not done that before. But it means you got to start forming the relationship, thinking about how that could work in the future and how we're going to go down that road. Now, I think in Lifelong's case, I mentioned the issue. We're interested in health homes. We're interested in whole person care outside of our provider role. But also, we have to rethink what we're doing with our over 60 health center. So, how to say that? I think it's going to mean for us more care at home, more electronic communication with our parents, or with our patients, maybe your parents, as the population grows. Increased ways of thinking about using community tools, virtual community tools, urgent care. How do people want to get care? Where do they get it? And how can we change? Which is really hard. It's easy for me to say conceptually, but it's really hard on our providers to think about doing something differently than how they've been trained for all these years. So, okay, going out the door because Wendy's peeking over the sign that says time. So let's remember, we still have to advocate to protect the ACA, and we got to grow those champions for elderly. work. You know, this group of people in the state looking at an initiative around LTSS coverage. That's a really good thing, whether it passes or not the first time. We got to stand up for older people, and we got to plan, and do it differently. So that's where I'm coming from as I think about the world as a provider of these kinds of services. Thank you.
Thank you, Marty. Okay, terrific. We're really getting a sense of the systems, and really the repeated theme here is collaboration. It is partnership. It is about this messaging and communication with real services. So, Randy,
All right.
next.
Thank you. Good to see everyone. Happy Friday. Honored to be up here. My name is Randy Morris. I'm the Assistant Agency Director of the Adult and Aging Services Department in the Social Services Agency. And the Social Service Agency is a very large piece of the safety net in this county in terms of government programs. 3 large operating departments: the Child Welfare Department, the Public Assistance Department that has Medi-Cal and CalFresh general assistance and employment programs. And then the department I manage has programs that are probably familiar to this audience: in-home supportive services, Public Authority, which is a branch of that program, the Area Agency on Aging and Veteran Services, Adult Protective Services, Public Guardian, Conservator, and Administrator. And also sort of near and dear to, I think, what Rebecca and Marty and Alameda Health System, soon to present, will say, from 2011 until 2015, the way our agency was organized, and when I had this position, I also had the Medi-Cal program and was responsible on the Medi-Cal eligibility and renewal side to work with all the partners at the table. And I think I just want to key off of Rebecca's comment. The great success in Alameda County was completely because of partnership between healthcare, social services, and community that saw those results, and it was an honor to be part of that. And I see that effort is very similar to what we're talking about today: stronger together, let's not build walls. All right, it works. Okay, great. So to the question that we've all as panelists been asked, you know, what do we do? You see the little picture of a silo. Very inspired by our keynote, by the way, like Rebecca, trying to think about these words. And silo is such a pejorative term, and I'm going to make a comment about that, but it is true. We have these silos we have to manage based on a lot of federal and state categorical funding and regulations. But what do we do to take a system in the aging side of the safety net of systems and align the fragmentations? And I'm going to just speak briefly to 3 efforts that my agency is working on. And they are, first and foremost, not to underestimate the power of a county and a community to really innovate and inspire change. But you have to balance that with the need to be where big decisions get made. And I'm just not going to speak to DC, but I'm going to speak to Sacramento, because we have a very progressive state, and I want to talk a bit about what we and my agency are doing to make sure we're present in Sacramento. Second is, and really front and center what this panel is talking about, a lot of work in the last 3-4 years to really focus on getting this type of community, people in this room together, and say a bit about that. But then last, and I think to this issue of silos, and maybe inspired by the keynote, to kind of rethink silo is not pejorative, but these silos are programs that are critical pieces of the safety net. And as we innovate, as we look to collaborate, we can't keep our eye off of the need to make sure our programs remain strong, because they are vital pieces of the safety net. And I just want to say a bit about what we're doing there. So, in the state, for those who don't know this, as I promoted up in the government system, a lot of the work, and it's not exclusive to government, but a lot of the work that we do to run programs at the county level happen as a result of changes in DC or Sacramento. It could be regulatory, it could be legislation, it can be a mediated settlement in response to a class action lawsuit. A lot of activity, then the devil in the details, gets organized and put forward in instructions that come down to counties, at least as a government agency, to how to implement and move that forward. And there's often a very great distance between the way legislation is written, regulations, settlements, and then how you actually implement that. And that work is often done through state associations. A byproduct of the fragmented aging network is I actually have 5 different state associations that we pay state association dues to, because the work of the programs I manage live in 5 different state associations. Surprise, surprise. So I'm just going to speak to 3 of those today, because we realized, and we needed to, as we were looking at what we need to do locally, we have to be in the room in Sacramento when those discussions are happening to move things forward. So what do we do? Our biggest organization is CWGA, County Welfare Directors Associations. There is a committee of adult directors like myself, and a year ago we realized there was a need to bridge better to the directors of our agencies who most often didn't grow up or work in the field of aging, to be able to better educate our directors to speak to what to do in Sacramento. And we actually created a sort of tri-chair organizational structure to have a person at my level working with directors in our state association, and I was nominated and hold that seat right now and get a chance to kind of work with directors to talk about how to frame our state association work. We also have subcommittees in APS and IHSS, and managers in my department have been chairs of those committees and the regional committees. So we're very present and active in all the work of our CWGA programs. The California State Association for Area Agency on Aging is a whole other state association, and we have our AAA director who's here, Tracy, who is on the executive board of that state association. And there's a lot of meaningful work being done in partnership with people here, but to be in that room in Sacramento also is important to help guide and influence and help bring the voice of the local to that table. And last is the California Association of Public Guardian, Conservator, and Administrator, but Guardian in particular, the probate court, is a whole separate state association that has a very meaningful role in terms of some of the most vulnerable elders in our community when they get conserved and their civil rights are suspended. And very proud to say our manager, Alicia Morales, who's here, was just sworn in as the president of that state association for this current chapter. So we are in Sacramento. The joke amongst my peers is you can't mess with Alameda because we're in the house and we do a lot of work at our state association level. And then just to end on this particular piece, we also have to collaborate across these associations, which is work we're beginning to do. So, I got the Wendy nod. Okay, so locally, Rebecca mentioned, and I will say a little bit about, and for those who are here to hear the video, Joel, who asked the question earlier, is hired jointly funded by Healthcare and Social Services to create a new position to help create a new council. This new council is essentially a collaboration with public, private, and most everybody in this room, I see a number of people, to sort of bring people from the entire cross-sector of people invested in aging to sit together and figure out what to do to make sure, at least in Alameda County, despite the fact we can't change the federal and state regulatory funding trajectories that put us in silos, that we sit together and think above and beyond that and figure out what to do, not only locally, but then how to organize ourselves to advocate in Sacramento and DC. And as you see, we have 3 committees that we're starting to form. We're really starting to key off of data. Rebecca mentioned earlier a lot of data from her organization, Kate. We're trying to bump data across our systems together to better tell the story that aren't just anecdotes, but based on real data. We are also trying to do what we do well in Alameda County for children's poverty, homeless issues, and that is to bring together legislative packages that are really representative of the whole community. I don't think we do that as well in aging, and so we are working to make sure we improve in our efforts there. And last, the next panel has 2 cities that are going to speak to the age-friendly effort, so I don't want to steal their thunder, but we're really trying to figure out how can we make sure that the great work of many cities, we can think about how to do it as a community and pay attention to unincorporated. And then lastly, in terms of at a local level, new partnerships forming for sake of time, I just want to give an example of, and another shout out to Wendy. Last year, her keynote speaker, Dr. Margot Cashel, I got you 1 minute, okay? She really spoke to her findings of a Oakland cohort, National Institute on Aging funded, that looked at what is going on in the city of Oakland, which has become a national report about who is homeless, particularly 50 and over. And what it inspired us to realize is that many, many homeless are actually connected to family, but those family networks can't come together to figure out a way to help these people live not homeless but in homes. And a vast majority of them are Medi-Cal eligible, if not enrolled, and IHSS eligible. So we actually have a whole pilot that has started in partnership with the Whole Person Care pilot and some of their housing navigators, Justice and Aging, I see Claire here, and Margot, who was the keynote last year, to try to figure out what to do. We championed that at our state association conference, and we actually have a number of counties trying to figure out how to replicate some of the work we're piloting here to help chip away at a huge epidemic, which is homelessness, by taking some of our current programs to do that. And then lastly, I want to say just a little bit about this issue of making sure we continue to run our programs. You can't partner well and collaborate well if you are standing on a flimsy foundation. And as under-resourced as these programs are, we have to keep our eye on making sure they are resourced well, they are effective, and they are value added. So when we come to tables, we have something to bring to the table. So just briefly touch on one item in each of the three areas. Area Agency on Aging. The federal government mandates that every 4 years we have to develop an area plan that speaks to what are we going to do to help support 60 and older in our entire community. Last round, thanks to a lot of people in this room, we developed a very comprehensive plan, and we have to do that plan again in 2 more years. So we need to kind of be thoughtful of how we're going to do that. And we have a whole procurement process coming up for our CBO network. I spoke about in-home supportive services. I think it is low-hanging fruit from the policy world because it really is an extension of the healthcare safety net. It's a Medi-Cal funded program, and if you didn't know this, it is a $490 million program in Alameda County. It's a massive cost center, and it raises a lot of questions about what could it do to help achieve a lot of the goals that are near and dear to the healthcare safety net. And then finally, I just want to end on, it's a little bit depressing, but I think we have to keep an eye on this as a social service agency with the child welfare system and the elder justice programs we manage, adult protective services and public guardian in particular. As the population grows, the silent epidemic of a very small but important subset of our aging population getting exploited, mistreated, financial scams, we have to figure out what to do to raise awareness and work together. It's unacceptable, and it's a growing silent epidemic. So that is important work. You might have seen on Comcast locally, we have a commercial that is out now as one example of trying to help make sure people are aware to call us at APS to see what we can do to help. So that is my presentation. Thank you.
Well, good morning. It's good to be here. I'm Richard Espinoza. I'm the Chief Administrative Officer for Post-Acute Services at Alameda Health System. And I think the biggest piece that we're seeing here is collaboration. I would say for our system, we're doing a lot of internal change. And one of those changes is how are we working with our partners here at the table, partners in terms of housing, food security, legal assistance for our older adults. And the internal changes that we're doing within our system, and I would be remiss if I didn't point out Dr. Claudia Landau, who's here, who's one of our gerontologists for our system, who really is at the forefront and a pioneer for our older adults within the system. We're doing many programs that, thanks to Claudia and other team members within the system, have been picked up and are beginning to run with them. So what I wanted to start with is just to give a brief overview of the system, and give you an idea of what we're currently doing, because the system has grown a lot in the last 4 years. We currently have outpatient services, which consist of PT, physical therapy, speech therapy, occupational therapy. But it also has our fall prevention program that we're talking about language, moving to our mobility clinic that Dr. Claudia Landau has worked on, which really focuses on our older adult population. We have our ambulatory specialty services, both primary care and specialty. And we identified that we needed to have a gerontologist in our ambulatory space because we are seeing older adults coming through our doors, and we weren't meeting that need. And so we currently have a gerontologist, Dr. Seaback, who's in our Eastmont building 3 times a week, which is really assisting that group in meeting the population that we're seeing and getting the specialty services that that population needs. We have our acute hospitals, which is Highland Hospital, but we also have our San Leandro Hospital and our Alameda Hospital. And which is interesting is that our community hospitals, Alameda Hospital and San Leandro Hospital, have an older population. We might not see it as prevalent in our Highland campus, but we certainly do in our San Leandro and Alameda hospitals. And hence, as Rebecca had mentioned earlier, we have a collaboration with the fire department in Alameda to make sure for the older adults that we're seeing that are routinely coming to the hospital, that we're putting items in place to make sure that we're doing preventative care so that they're staying home and not coming back to the hospital as frequently as they were before. We have our behavioral health services at John George, and then we have our post-acute services, which encompasses 340 accommodations between skilled nursing, subacute, and acute rehab. And the reason I point that out is that we're seeing older adults intersect all of our departments and across all parts of the organization, and that the system is really focused on delivering care across the system that's integrated. So I think we're moving, even within our own system, from a siloed effect to making sure that we have behavioral health across the spectrum, that we have gerontologists who are speaking out and encouraging how do we build programs to make sure that we're meeting the needs of our older population, and making sure that we're continuing that work and shifting that work. Some of the system adaptation that we're currently working on is population health, as we understand that there is a complex interplay between social needs encompassing housing, food security, legal assistance, and health. We want to make sure that we're focusing on whole person care and the full spectrum of needs, not only just physical and behavioral health, but social and economic, and how that really has an overall impact on our older adults' health. We are really having a concerted effort to make sure that as we're seeing our older adults coming through our acute hospitals, that we're connecting them as we're discharging them back into the community to primary and specialty care services within our ambulatory care. So as I mentioned earlier, where we have gerontologists within our ambulatory space to make sure that we're helping with preventative care, making sure that we're looking at healthy behaviors, whether it's smoking cessation, whether it's diet, making sure that we're sharing information on exercise, again, mobility clinic on keeping older adults safe, preventing them from falling, and looking at routine visits. We've identified that older adults tend to stay home and may not come to their primary physicians. And so how do we help collaborate those appointments so that we can get them in routinely as that preventative care? We have an organization within our group called Health Advocates, and our Health Advocates is a group that's comprised of undergraduate and graduate students who volunteer with our clinicians to be navigators for our older population and our population in the Alameda Health System, looking at housing stability, making sure that our older homeless adults have access to housing, looking at safer housing, do we need to find housing that doesn't require stairs, looking at income and seeing if they need housing that's more affordable for our older adults. And having these navigators is critical. The system is so complex that if you don't have navigators, it's for our older population, it's where do you go, where do you start? And so this program has been really effective in helping getting our older population the services that they need within our community. Part of that is looking at improved food security, and we're really shifting culture. And so instead of looking at our older adults as leaving skilled nursing facilities and staying in skilled nursing facilities forever, that we're really empowering them and saying, how do we get you back home? How do we get you back in the community? And we can't do that alone, but really utilizing our community partners so that we can have our older adults stay at home. Some of our service delivery, as I mentioned, is our post-acute services, which I just want to put a little ad in there that we're 5-star rated by CMS and 4-star rated at our Fairmont facilities, because we really focus on resident-centric care. The focus really is short-term rehab so that we can have our older adults back into the community, whether it's in our acute rehab and then refer them to our outpatient services, because again, we really want them to stay home and in the community. Again, having gerontologists in our acute settings and ambulatory settings. I do want to mention a great program that Dr. Landau and our partners with Daybreak and the Oakland Senior Centers with our Eritrean community, that they're meeting twice a month to have Tai Chi classes, Mahdi, which means a shared meal, and so that population is not feeling isolated. It's one of the programs that we're working on to build community. Again, the fall prevention and mobility clinic that we have at Highland. And one that we're really excited about is what we call in our think tank, is that we've discussed a medical home for older adults. It's very in the early stages, but a clinic where we have a gerontologist, physical therapist, case managers, social services, to really help keep our older adults in the community and not coming into skilled nursing facilities. Lastly, I want to talk about collaborations, because to me this is the biggest piece and really why we're all here, is how do we continue to collaborate together so that we can make sure that we're really keeping an eye out for our older population. Again, our health advocates that really assist our older adults with connections to the community. We, as Rebecca had mentioned earlier, Alameda County Care Connections, we're really focusing on from our acute settings and our skilled nursing facility settings, connecting our older adults with services to go back home, housing, utensils, things of that nature, so that they can live independently. Working with East Bay Innovations, California Community Transitions, that really works on extensive housing search and transitions through the SNFs. And lastly, it was mentioned earlier, the Alameda County Council for Age-Friendly Communities. I think the biggest thing, as we've talked about, is collaborations, is that we can't do this alone. And as a big health system and a safety net for our older adults and for our community, it's impossible. And so having everyone here is so promising, knowing that we're all in on the same endeavor to make sure that we're delivering the best care for our older adults. Thanks.
Thank these leaders of such critical health systems and systems in general for Alameda County. What a wonderful presentation. And some of the stage was set this morning with the opening video, which it really profiled real people doing real programs. And then our inspirational keynote talking about framing and how we think about things and our actions and advocacy. And takeaways just from these presentations are really about the thread, making the story of us. I see that folded into each of these presentations and the language around that. So we have a few minutes here. I'm going to tee off with some questions for each of our panelists. In the meantime, you've got some cards at your table. So if there are questions you'd like to ask our panelists, please go ahead and write those down. Rebecca, I'm going to start with you. In this complex world of aligning scope of services and costs and outcomes, and all doing it with a sensitivity toward people, all of us. Tell us a little bit more about the work of systems in terms of working collaboratively with community and faith-based organizations. You mentioned that, and also maybe some of the opportunities. You had highlighted complexities, but also opportunities. So a few words about that.
Well, we are open and kind of striving for new partnerships and striving for innovation. And we are looking at ways to partner and provide technical assistance to bring new providers next to government. We know that community-based providers have more knowledge, more cultural competence. They are deeply rooted in the community. So we're looking for ways to partner. We know that working with government can be challenging, so we're interested in providing technical assistance and sitting down and figuring out how new partnerships can work. I'm really excited about innovation, and you probably know, or you may know, that the Healthcare Services Agency has really focused on place-based services and have been shifting some of our service models from clinic-based services to going where people are. We put backpack doctors into the community, working and going out to encampments and to creek beds where homeless people are. We have behavioral health clinicians in over 300 schools in Alameda County, and moving towards home-based services for older adults is part of that shift. Some other new partnerships with providers that we've kind of been thinking about, I think they're piloting something in Fremont related to putting primary care or doctors or nurses in the senior centers. I think that is a really exciting option that we would want to look at. So we want to try things that haven't been tried before, and we want to partner with community-based organizations to do those things.
Great, thank you. Marty, you had mentioned a little bit about some of the political challenges that are presenting themselves today, and so we thought we would ask you a little bit more to tell us a little bit more about sort of the policy and funding threats from DC, but also really thinking about it in terms of activism and advocacy, and where is that opportunity as you see it?
Sure. So one thing is, if the current administration succeeds in cutting back resources, I think not only is it going to force us all to think about what we do, but I think it's also going to force us to consolidate in some ways. So that's just a start off. I'll tell you a lifelong story. When the presidential election happened, we got really worried, and we established something called the Lifelong Advocates to encourage our staff to be active in this world of attack and being under the gun all the time. And what we found is our staff became much less depressed about all of the bad things that were being said about their programs and such when they had something to do. So we staffed that, we got notices out so people could make phone calls, do emails. Some of our sites had doctors and other folks come in early before the workday to do together in our conference room or group room calls and such. And it just created a different feeling. So, you know, I would think about, most of us come out of a mission of advocacy and social change. This is certainly the time to accept that, enjoy it, do it. It's hard, but we really need it right now. So I think that's one of the ways that I think about it, as well as I got to go to Randy's point, which is all these associations that we're all part of. We're part of all these health center associations. Well, key time for advocacy at local, regional, state, and national levels in our associations. And when we get up to national, it's harder because not everybody thinks the way California does, in case you didn't know. But so that's how I think about it, Monique, in terms of the need to be active when we are under threat, and certainly not to be quiet.
And it sort of echoes also Maria's presentation about just thinking about it. It's not that it's not depressing, some of these threats, but thinking about the opportunity that's there. That's terrific, reframing it. So, Randy, you had mentioned, just sort of tagging on to that last comment about being part of the state associations, really thinking up and down the ladder and the lattice, if we think of structure and architecture, but how we approach problems and problem solving. And so thinking inside and outside the box, where do you think perhaps there have been some overlooked challenges, as well as some opportunities with systems change to address some of those challenges? Things that may be not seeing the light of day as much, but are there.
So two things jump out at me, and I want to disclose they come from my experience starting my government career in child welfare, when the child welfare system was going through dramatic reform. And something Rebecca said earlier in her comments reminds me how hard it is to kind of bring people together. It's kind of a little easier to sit and huddle in your silo. And then the Medi-Cal expansion in Alameda County, that in 2011 I got here, and we were just sort of gearing up because 2010 had passed. And in both of those experiences, profound reform, two things jump out at me as this panel is now talking about the aging safety net. One is, and I just feel obligated to say this, it's so high school, but whether those of us in positions of influence or authority get along or don't get along at the relationship level, I cannot underestimate how much influence that has to the positive or to the negative, whether you figure out how to get along. I have experienced no malice in anyone's efforts, but sometimes things are annoying when systems are coming together that don't know each other. And so I do think that we have a really great start, but it's a new process to bring the aging network together, get out of our silos, and we have some more work to do to build and strengthen on those relationships. And then the second is, it does strike me that in both the child welfare reform discussions and the Medi-Cal efforts, Alameda County is, I think, pretty impressive in how much it champions and embraces the diversity of the Alameda County community. It's one of the most racially and linguistically diverse communities in the United States of America, and there is a profound amount of discussion in child welfare, disproportionality issues, and to credit to with Marty and Rebecca and AHS all sitting here, the diversity of the FQHC systems. I don't find that we talk about it as much in the aging network and put that elephant on the table. It happens, there's diversity, but I think we have more room to discuss diversity in the aging network as we work together. Those stand out.
That's a lovely springboard. Thank you for Richard's question, because Alameda Health System, of course, is managing, as you presented, a huge array of services and also addressing the needs of diverse communities, and many of whom are individuals who are disenfranchised or have limited access, for sure. So maybe just could you chat a little bit more? You highlighted some of these really innovative programs that the health system is promoting and providing, but talk a little bit more about the support and the sort of the framework that you're using as a health system to address these unique needs, and any sort of visionary ingenuity going forward. How's that for 2 minutes?
Sure.
So I would say that, internally that we have a lot of thought on, one, really focusing on our internal changes, making sure that we're giving support across the system. I think it's a system that has grown and has come together very quickly with the adoption of St. Leandro and Alameda Hospital within the last 3 years. Also with our big post-acute footprint. So I think we really are working internally on making sure that there is stability, as Randy had talked about earlier, making sure that we have a strong foundation. We're looking with our health advocates group where we have our, I think I spoke to this earlier, our undergraduate and graduate students who are volunteering to be navigators for our older population. Also speaks to our collaboration with the next generation. We want to make sure that as we have a workforce that's aging, that we have a connection and a collaboration with students who are wanting to work in the healthcare field or who are wanting to work in social justice, and connecting them with our older adults and helping them with our collaborations with our community partners and in placing and housing and food security and legal assistance. And it really is helping us connect the next generation to what we're doing and looking at potentially them replacing us as we age out of our work.
Absolutely. So thank you very much. I think we've got some questions from all of you. We're going to kind of go through those and okay. All right, so let me see. So this is for you, Randy, and just going back to your association discussions and really elevating the importance of having a seat at the table. We hear that over and over again. Find and take the seat at the table. And you talked about sort of identifying a shared language with other members throughout the state. Talk about really sort of expanding that perspective, not so much taking the Alameda County perspective and then really knitting together a larger effort to promote change throughout the state. Your example and how you might do that through these state associations. I hope I have that right, by the way.
Okay. Well, for those of us in positions up at the panel, I kind of think of it as a bridge. Kind of we need to both listen locally across our systems to people doing the work, consumers of the service, and then our positions afford us the privilege and responsibility to sit at some state association tables. And I think what's paramount here is if you go sit at a state association table and you only have a frame of reference of your silo, you might be advocating something that makes sense for your silo, but it has an unintended adverse consequence on another corner of the network. So I think to the point of what we're talking about, the more we can level set, learn, listen, the better positioned we are to be in tables in Sacramento to speak more holistically about where the system's broken. And I could give you many examples within just those state associations that we pay for, where one state association has put something forward that has caused a problem for the other state association that we both, and so then broaden it out to how do you think about the impact on the healthcare safety net and the local community clinic. I'll end with the positive. I think a lot of what we're trying to do at this age-friendly council in our governance work and sort of building that network is listen and learn, because a lot of us then can take that information and I will tell you, it has caused me to speak a little bit differently in a nuanced way at those tables because I'm more thoughtful and more aware of those who are impacted by things we're fighting for. So it's early work, but I think we're doing it.
You had a comment?
Yeah, my comment is quick. I think it's no time for lone wolves is what we're under threat and it's time of change. It's time to be part of these associations. Randy says over and over again, we pay to be part of these. Well, I think we should all be paying to be part of them, and the fact that you're here today is a really good sign.
Great. Okay, Rebecca. So we're talking about the Healthcare Services Agency and really the tremendous amount of collaboration that you not only have initiated already and working hard to continue to develop and grow, but with all the data you have, what is the story you envision will be effective with your work going forward? I mean, sort of thinking about the solutions that are coming out of these partnerships and collaborations, but sort of the big picture going forward with all of these efforts, the cooperative efforts, the data.
Should I focus on older adults or
Yes.
all of them?
Yeah, we'll try older adults.
There are a lot
Yes.
of areas that we're actually doing cross-systems work. in the area of older adults, my end game, which I raise at almost every age-friendly community, council meeting, and all of our internal meetings, are preparing for the future now. We know that we're going to have a population growth. We know that we have to be activists with respect to resource acquisition, and how are we going to get those resources, and where are we going to deploy them. Those decisions can't be made by the health department alone or by social services alone. The partnership should drive how we invest and how we prepare for the future. So a lot of this is, as Randy said, we're learning from each other. We're changing by listening to other systems. So a concrete example is the slide deck that the CAPE unit prepared on Alzheimer's in Alameda County. They are experts in data acquisition, they're experts in developing slide decks, but really what they need are the Alzheimer's community-based providers to come and inform and ask the questions, what is the data telling us? And so we are in a receptive mode. We are listening to community-based providers. We're having you all help us interpret the data and then figure out where we go from here. So I'm just kind of underscoring what Randy said. If we're going to work together, we all need to listen to each other and learn from each other. And it's government learning from community-based providers and partners. It's also partners learning about what the requirements of government are. And as someone who is an infrastructure person, many of you know I'm the finance director of the Healthcare Services Agency, who was asked to serve as the interim director. So my knowledge is in finance and infrastructure and how you make government do what you need it to do. And it's complicated and there are rules, but you can do it. You just have to be patient and invest time in learning about government in a parallel way as government is trying to be receptive and learn about you.
Great. Thank you. Richard, this is for you, and this is really addressing some of the post-acute care issues that you highlighted, trends toward community living, supported community living when it's appropriate, understanding that perhaps facility-based care, skilled nursing facility-based care is certainly appropriate. But the question is, we have individuals who may need a more supported living environment. So would you address the need for assisted living, so residential care facilities for the elderly, boarding care homes, as well as medical respite, those programs that provide services to individuals who need interim medical care post a hospitalization, who are generally homeless?
Sure. So our skilled nursing facilities comprise of two populations. I would say one population is our short-term rehab, so someone who's fallen and broken their hip, needs IV antibiotics, wound care. Our goal is really to get them home within 14 days, get them back into the community. But then we do have our long-term care population, who are older adults, maybe in their 90s and 100s, who don't have family, who don't have support services, who do need to be in skilled nursing facilities. We are collaborating with all the skilled nursing facilities in our county to make sure that we're collaborating and working together. There is a need for assisted living. There is a need for more boarding care support, and so we are doing some outreach with some of those organizations to make sure that we are also collaborating. We're looking at what we can do within our own system. We're moving our acute rehab to San Leandro Hospital in the next few years, and so there's some thoughts of what do we do with that space when we move out. So we haven't committed to anything, but we're really thinking about how do we make sure that we're meeting the needs of the community, how do we make sure that we're collaborating with boarding cares and assisted livings. Our skilled nursing facilities and a majority of the skilled nursing facilities in the community also provide respite care. So through hospice services, we can provide respite care so that younger adults who are taking care of their parents, for example, can have their parents come to our facilities for 5 days, 8 days, so that they can have a break at home, be with their families if they need it, and then they'll go back home. So we do provide those services as well currently.
Great. Okay, we have one more question. Oh, we have a few minutes. Okay, so Marty, you really presented this rich overview of all the services that Lifelong provides, and also really talked about this active advocacy and activism and your group of healthcare, is it called healthcare advocates that you're, right. So this question wants to know, this individual would like to know a little bit more about really developing the messaging or framing persuasive around, I hope I have this correct, technological solutions. And as you talked about portals and maybe potentially telemedicine or telehealth, primary care in the home or home-based care, can you talk a little bit about how working with your provider groups, getting them to really accept that, and or perhaps even working with individuals whom you serve and using some of those new technologies to both provide and receive services?
Do my best. Maybe the framing question is for Maura, but I'll tell you that even in our elderly population, you guys know this, almost everybody's got a smartphone at this point. If they don't have a smartphone, their family member's got a smartphone. And, we got to interact with people the way they interact with the rest of the world. So that's one of the ways that I think about it, tremendous opportunity. But last night I was at a provider dinner that we have every couple of months, and it's a guy who's a psychiatrist at our over 60 site. He was telling me how excited he is to roll out telemental health at over 60. He's been doing it for a county up in northern California where he works from home, right here in I don't know where he lives, Oakland or Berkeley. He works from home to provide mental health services. Well, now we're going to try rolling that out to people who have a hard time getting out of their own homes, where they can get psychiatry and counseling services in their home. We send somebody in with I don't know, we're using an iPad or a PC, doesn't matter, whatever the tool is, and extend the ability to get those services out. So, my attitude is, again, how do we do them where people want them? How do we make it easy to happen? How do we use the technology? I'm a Luddite. I mean, you said you were 59, I'm 68, right? Of course, I love my devices, but still, I'm not thinking creatively as some people are. I think it's a whole new opportunity to create virtual communities, virtual services. Some of what I hope Steve will talk about is virtual community ideas. I just think, we have an opportunity in front of us that uses the technology for monitoring, communication, virtual support groups, people who have diabetes supporting each other, not in a room, but online, we're seeing that kind of stuff. We got to do it.
And with that, that's the last word, and we'd like to thank the whole panel, Randy and Richard, Rebecca, and Maureen.